So let's get started. Our first session, Engaging Agenda Setters, Making Cardiovascular Disease Prevention a Priority, will be moderated by the National Forum's incoming Vice Chair, Laura Gordon. Laura is General Manager of the Federal Government Services Practice at Edelman, a global communications marketing firm, and she is widely recognized expert on health communications, a tremendous contributor to the National Forum, and in particular around outreach on our vital programs. So, Laura, thank you.
Okay. Is my mic? Yeah. Okay, there we go. Well, welcome everyone. I'm really thrilled with our panel today. We have some esteemed folks who are doing some really pioneering work in their respective areas. And we want to start the discussion. Each of you has our signature report you should have with you this morning. This is something really special that I will say has the blood, sweat, and tears of Dr. Steve Sidney right in this paper. So please, I hope you'll really enjoy the format and sort of what we put together for you today. But the whole point was Steve, sort of the genesis of this was Steve talked to us about some data that were out there that he really wanted to capture in a way that would highlight the need for exactly what the National Forum does every day. And I'm going to let him do the real talking about it, but this is something that we are releasing today. We have released it to media. It is on the website. We'll be tweeting out links to it and some of its components. But very important look at what's happening with stroke and heart disease death rates and maybe how we can address that. So first I'll introduce our panel and we'll talk a little bit about the report and then engage our panelists in discussing how we might address this. So I will start with Dr. Steve Sidney. He is Senior Research Scientist and Director of Research Clinics at Kaiser Permanente, Northern California. And then our panelists who will be part of our discussion are Dr. Mike Cropp. He's President and CEO of Independent Health, which is an innovative community-based health plan in Buffalo, New York. And Dr. Clay Marsh, who is Vice President and Executive Dean for Health Sciences Administration at West Virginia University in Morgantown. So with that, Steve, let's talk. Let's get down to brass tacks, as they say. Your report highlights some concerning recent trends in the rates of heart disease and stroke deaths in the United States. So if you would just tell us in a bit of a nutshell what's been happening.
Well, what's been happening basically is that for many years, and the report itself focuses on the time since the year 2000. For the first decade, the decline in mortality rates from cardiovascular diseases overall, heart disease and stroke in particular, which are the largest components of cardiovascular disease, had been declining at a very rapid rate, 33% actually. It went down about a third between 2000 and 2010. And then around 2011, an interesting thing happened, which couldn't really be observed until a few years later, is the rate of decline slowed dramatically. So where the annual declines had averaged about 4% or so for these causes of death, they trickled down to less than 1, in some cases very close to 0. So something happened, and then that happened when we observed it with the 2014 mortality data. In 2015, actually heart disease mortality went up for the first time in about 22 years from the previous year, and stroke mortality had gone up for the past 2 years. So that is the problem, basically, that the great advances that we've been making for a long period of time seem to have deteriorated. And it is further complicated by the fact that the population's getting bigger and it's getting older. So while rates could stay the same, but because the population's getting bigger, And because the older part of the population is getting bigger at a rapid rate, and that's the population that tends to get these diseases, the actual number of deaths is going up, and that reflects on the burden to our healthcare systems. So, for example, the number of cardiovascular disease deaths increased by over 50,000 between 2011 and 2015.
So I know this is speculation to some degree, but I think you have a sense of some trends or factors that might be contributing, to this issue.
Well, those of us who've thought about it, the thing that really sticks out are there's 7 kind of characteristics of a healthy heart, lifestyle and physical makeup. Some of them are going in the right direction or staying stable, like blood pressure control, cholesterol, smoking. Diet is one of them. We can't even really measure it that well on a population basis, or haven't been able to detect trends. And physical activity, it's uncertain. But the 2 things that stand out are we have had about a 30-year or so obesity epidemic, where the rates of obesity have tripled over the past few decades. And when you have obesity, you have great increases in the rates of diabetes. And diabetes is a powerful cardiovascular risk. So our biggest speculation is that this is certainly a major contributor to what's been going on. And it took a while for it to manifest itself because it takes a while for these diseases to do their damage.
Can you talk about heart failure? That was a particularly troubling trend, and I think you have some thoughts about what's happening with that.
Yeah, one of the things that we've done is we've taken a look at the major categories or subcategories of heart disease. The biggest one is coronary heart disease, ischemic heart disease, heart attacks. And that's by far the largest, and that has gone down reasonably steadily, though it has slowed down over the last some years. The second biggest cause of mortality from heart disease is what's attributed to heart failure, the inability of the heart to pump properly and get the blood around. So the number of deaths has increased by about a third, and the rate has actually gone up pretty steadily over the last 5 or 6 years. It's some people argue about this is that, well, maybe it's just the heart failure that a lot of people get after they have a heart attack, and maybe it should be called heart attack. It's a little unclear, but the fact is that heart failure is felt to be a disorder that is going up at a great rate, the diagnosis of it, and the mortality that's attributed to it is going up at a fairly rapid rate. Why this is happening, a little bit unclear. The things that we do know that heart failure is somewhat more difficult to treat and manage than coronary disease or ischemic heart disease. And there's also a variety, there's 2 varieties of it depending on how well the ventricular, the heart pumps. And a so-called preserved ejection fraction, which is, the heart seems to pump well, but there's problems in one of the phases of the heart in diastole that causes heart failure, that this is particularly hard to treat, and unfortunately we don't really know what the distribution is between the so-called preserved and not preserved heart function, heart failure.
So stroke was another area that actually the deaths increased between 2013 and 2015. What do you think is happening there? And I think also there was, I remember in the report you noted increased strokes among younger people.
Yes. I think what's happening with stroke is the same thing that's happening with cardiovascular disease overall, and that likely the biggest contributors or the obesity, diabetes epidemic. The same kind of pattern, though. We had tremendous declines during the first decade that have slowed down considerably. And the second
The
part
younger people.
Oh, the younger. Yeah, there's been several observations now, studies, including from the CDC, showing that stroke rates may be going up in younger people, which is particularly troubling since younger people become older people. And if you think these patterns are going to continue, it does not bode well for the future.
Mm-hmm. So I wanted to talk a bit about disparities among gender and race. First with gender, it was interesting that it looks like the death rate decline, the declines in the rates happened very similarly among men and women, yet there's still disparities by gender with heart disease deaths. Can you just talk a little bit about that?
Right. Males have a much higher, what we call age-adjusted, rates of heart disease mortality than females. Though it is true that since women, by and large, live to an older age, the number of deaths is not that much different. Mm-hmm. So these disparities exist in ischemic heart disease mortality, much higher than men and in women, and in heart failure, interestingly, not so much in stroke.
Mm-hmm. And how about race and ethnicity? I think we saw the same thing.
Right. In race and ethnicity, heart disease and stroke are highest by a fair mark among blacks, African Americans, followed by whites, Native American, and then Hispanics, and the lowest rates among Asian Americans.
Mm-hmm. So you noted in the report that there may be some good news. We may see for 2016 data that things are going back in the right direction. Can you, do you think that, I know again, you're speculating, but do we think this is a blip, or do we think going back in the right direction might be a blip? Any thoughts?
I think that 1 or 2 years is not a trend. So, but I think we should be alert to the fact that because of provisional or preliminary data that are available on death rates, it appears that when we get the 2016 data, probably in a couple of months, it will show that heart disease mortality has gone down a couple of %. And stroke mortality has gone down a tiny bit from last year. I don't think in terms of the messages we're trying to get out here, we should be kind of tricked, by that. Basically, if you look at heart disease going up the way it did last year, and then coming back down this year, and then compare this year with 2 years ago, it's as if it stayed on the same slower track downward that it was before. And strokes, just really looks like it would be about stalled out.
So is your message remain vigilant? Is it something more than that? Do we need to pay closer attention to certain things based on this troubling trend for the past couple of years?
Well, I'm sure this conversation will be picked up by others, but I think, yes, we do need to be very vigilant. And the reason it's so good to have this out in front of the National Forum is that we have the partners here who can affect change and get us back on the right track.
Great. Well, with that, I'd like to start a discussion with our panelists, and at the end, we will take questions from the audience, so start thinking about what questions you'd like to ask the folks here that we have today. Mike, I'd love to start with you. So you just heard what the report had to say, and amid all of this, CDC says that at least 200,000 deaths from heart disease and stroke each year can be prevented. So amidst all of this, not only are we seeing these positive trends slow, but we know that many are preventable. So why in a country that outspends all others on healthcare could this possibly be happening? And talk a bit from your perspective.
Sure. I guess full disclosure to start. Buffalo, back in the
early 2000s had one of the highest incidents of death from heart disease of any region in the country. And anybody who's traveled through Buffalo or, at the airports, when you see the flights to Buffalo, you can pick them out in terms of body habitus. And it's a challenge. And I don't think these are related, but, Buffalo's known for a couple of things, chicken wings and beef on wick.
Which are delicious, by the way.
They are. And you might think it's a conspiracy to bring the rest of the country up to Buffalo in terms of death rate from heart disease, but they're unrelated. So just full disclosure on that. We've been on a journey for almost 20 years now. Started working with primary care physicians with the Institute for Healthcare Improvement back in the late 90s in redesigning care in the office to try and capture more of the upstream opportunity in terms of managing the risk factors of heart disease and other conditions. And as we began to work with the primary care physicians in that way, we recognized that it wasn't going to be enough, that there were other challenges that extended well beyond the office that we needed to address in terms of people's awareness of the risk factors of heart disease and the ability to impact them that extended beyond the healthcare delivery system. So we came together as a community at about the time Robert Wood Johnson Foundation had issued an RFP for a grant called Pursuing Perfection, which looked for organizations to really strive for perfection in treating two clinical conditions. And so we applied for that grant and chose the risk factors of heart disease as one of the conditions, and then the diagnosis and treatment of breast cancer as another. And we're finalists for that. Didn't ultimately get the award, but sort of kept at it and began to reach out to engage the broader community with this organization that we founded called the Pursuing Perfection Collaborative of Western New York. Ultimately, we were fortunate enough to be chosen as one of the original Aligning Forces for Quality grantees by the Robert Wood Johnson Foundation, and had, by that time, really struck partnerships with churches, with employers, with schools, to begin to address those risk factors where people spent their lives, at work, at school, in the community, and outside of the healthcare system. So that's kind of been the journey that we've been on. And along the way, we recognize that there's a really nice framework that we didn't realize that we were following, but now it makes a lot of sense. For any of you who've read the book Influencer, when you're trying to really impact something that has such a broad impact socially, they talk about the need to be able to impact motivation and ability at an individual, a social, and a structural level. And so that has really framed our work now in terms of how we approach our members, our provider partners, and our community to impact motivation and ability. And so we've had member benefit designs where we reward people for doing the right things. If you're healthy, doing all the right things to stay healthy, or if you have diabetes, or if you have high blood pressure, or you have high cholesterol, doing the right things to improve your state of being. And the member benefits are you get lower out-of-pocket expenses, copays and deductibles. And you don't have to put a lot of money on the table to get people to change. And then beyond that, we've been working with our physicians to reward them for doing the right things. So we're in a payment model now in our 5th year where primary care physicians are paid on a value basis and not on a fee basis. And so when you go back to that issue, the question about 200,000 avoidable deaths, and you think about all those risk factors that are out there in terms of diabetes, in terms of hypertension, cholesterol, obesity, there are a tremendous amount of missed opportunities along the way. And looking at it through the lens of our members, our community, and our providers, we're systematically looking to close each of those gaps through the benefit design, through the outreach that we have to the community, and then through how we engage the primary care physicians to focus on those things that really make a difference. So getting the simple things like, more consistent use of beta blockers after a heart attack. Beta blockers aren't very expensive, doesn't capture a lot of the sexiness of some of the other drugs, but if we train the primary care physicians' focus on beta blocker use and aspirin use, the dramatic increase in compliance with those two strong indications is pretty profound. And that's what we're seeing now with the primary care physicians. And we're seeing much greater degree of member engagement through our benefit design as well. So we feel like where we were in the early 2000s as a community, the next time that we really take a look at this, we're going to see a tremendous change in our community because of that approach that we're using.
And you mentioned focus, and you mentioned that when we spoke a couple of weeks ago. How important has that focus been on moving towards success?
That's been really instrumental because when we bring the primary care physicians together to talk and to share data, what we try to do is to highlight those best performing practices, but stay, as you said, focused on the key issues that are making a difference. And so those are the things that we share the most data on, the most consistency, and those are the things that we reward most significantly to make sure that the physician's attention isn't on the sexiest thing, but is on the basic things that they need to just get done for that population that they serve.
I imagine it answers also the worry that a lot of physicians have. It's like, if I have 12 things I have to remember, you're making me crazy. If I have 2 things I have to remember, that I can do in a busy day.
Exactly. And one of the things that we do now to help maintain that focus is helping the physicians in terms of the patients that are in front of them. Even with the electronic medical record, there's sometimes pieces of information that they don't have because care has been rendered outside of their office. Bringing that kind of information together through what we have in terms of claims or other sorts of information, and being able to chart prep a physician's day so that those gaps are front and center for them is helping to close the gaps and maintain that focus on a daily basis.
Now, this couldn't have been easy. So tell us a little bit about a couple of the challenges that you faced, perhaps early on, perhaps part way in, and how you addressed them.
Early on when we started this work with primary care physicians, we recognized, hey, we're a health plan, and they view us, with skepticism. We like to think that we're kind of the best of a bad lot. Realistic appraisal of ourselves. So when we began to work to identify gaps in care, we started working with adult practitioners on diabetes and pediatric practitioners on asthma, 2 conditions that were prevalent enough that there would be a big enough population in the practice that data collection could be meaningful. And so we sat down with the physicians, recognizing that they're going to be skeptical of our sort of presenting information to them. So together, we just looked at the science and determined what excellence in practice looks like for diabetes and for asthma, and then said, if we have agreement that this is what excellence looks like, then here's a scorecard that reflects that excellence. Now, here are 10 patients in your practice. Go back and take a look yourself at what you see. And everybody said, no problem, I'll take a look, I know it's going to be great. And it was a 10-point scale for each of them, and 6 points allocated to outcomes, 4 to process. People went back and looked on their own, and the average score is like 4.2. And by doing it that way and having them do their own sort of review, it got past the skepticism of we're coming in and our data's no good, and it got their attention. And that set the stage for people recognizing that While the average score was 4.2, this practice was scoring 6.5 or 7. And that innate competitiveness began to take hold, and then sharing began to take place, where this practice was sharing their best practices and vice versa, and things rapidly began to improve. But recognizing that as a health plan, we needed to approach it differently, that was an important lesson along the way for us.
And just one last question for you. The counterpart of that is patience. It's easier to control, I'll use that word, and sort of generally physicians and their practice when you're a health plan. It's much more difficult to impact how patients behave, even if there is a financial incentive. But was that an effective way to go about it, and were there special barriers there?
Yeah, the biggest barrier was New York State. In terms of setting up this this benefit design that rewarded people for doing the right things. It took us a couple of years for New York State to realize that we weren't setting up to penalize people who had a bad genetic hand dealt to them, that we were rewarding anybody who could do the right thing. And so once we got that going, it was interesting because as we were working with the doctors, particularly the adult practitioners on diabetes, and they were doing things differently in their practice, they came back and said, we're doing everything we can, but how can we engage our members more? And that's when we went to that benefit design feature. But it was New York State that really dragged their feet for a while. And still, we're still learning lessons along the way that it isn't just the economic incentive, but how can we go back to that influencer model and begin to help people in their work site, in their church groups, get the kind of group support that they need to encourage them to do more of the right things, and to help set kind of the activities and resources in the community to make it easier for them to do it as well. Because, like many inner cities, some of the people who live there don't have access to good foods, fresh fruits and vegetables, don't have access to places where they can safely exercise or walk or just be out. And so helping the community to begin to enable people to have access to those resources is another important part that we're still working on.
Mm-hmm. Well, that's a terrific segue to ask Clay a few questions. Clay, and you're when we spoke a couple of weeks ago, you talked about your vision for a healthier West Virginia. So really looking at how you can use your role and your system to help the entire state. And you talked about a couple of key components of that. One, incentivizing physicians to do the right thing, but importantly, you talked quite a bit about community and the importance of engaging many stakeholders. I wonder if you would kick us off with talking a little bit about that.
Yeah, sure. Well, it's a pleasure to be here, and thanks for all that everybody in the room does to try to make this a better country to live in, and your own places better communities to live in. So I have a couple of strong biases that I will acknowledge right up front. So I think that healthcare is our business. It's transactional, and health is our purpose. And I think a lot of times we've lost our purpose for our business. And for me, it's really stunning that, as I understand it, 71% of American workers are unhappy with their jobs. And in medicine, the biggest Delta group that is at risk to commit suicide is over 50-year-old doctors. So I think that nobody wakes up in the morning figuring out how many RVUs they can generate or what their Press Ganey scores are. We high-five ourselves when we have full hospitals, but that really is a failing. And if we want to save money and improve outcomes from healthcare, we should help people be healthier. And so if you believe, as I do, that everything is connected, that we could sit here and talk about heart disease and stroke prevention, but we could sit here and just as the same talk about cancer prevention. I was on Capitol Hill yesterday talking about opioid issues. I think it's all connected, and it's all connected in a complex system. And the two things I know about complex systems are they don't follow the same rules as the Gaussian curve, so it's not 95% in the middle and 2.5% on either end. The complex systems follow what's called a scale-free curve. And the scale-free curve means that only a few things are really important. Only a few things are the hubs, the things that make everything matter. Think about, so Malcolm Gladwell wrote The Tipping Point. And The Tipping Point, he said that you don't have to convince everybody to start a social epidemic. You need to connect, you need to convince the connectors, the people that know people, the salespeople, the people who try it first and say, hey, it's a cool thing to do, and the mavens, the people you go to get the latest and greatest. And if those three groups of people make that their priority, then you can start a social epidemic. And similarly, Nick Christakis wrote a book called Connected, and in Connected, he pointed out that if you wanted to immunize a community against influenza, and you just took all comers, then you'd have to immunize everybody. But if you knew the connectors, the people that were the most closely linked to other people in the community, which about 25, 33% of the people, you could just immunize the connectors and you get almost the same benefit. So for us, this idea about precision medicine, to me, should turn to precision health. And when we start to look at complexity and look at the percentages, we know, and this was highlighted in Atul Gawande's hot spotters, but it's out there. So the top 1% of expensive people cost us about 25% of the healthcare dollar. The top 5% of expensive people cost us about 50% of the healthcare dollar. The top 20% of expensive people cost us 80% of the healthcare dollar, which is the Pareto's principle, the 20-80 rule, that in every system, 20% of the agents or people or whatever account for about 80% of the activity. What's really interesting is the bottom 50% of the people, and this is Medicare, Medicaid data from 2005 because I can just remember it, but the bottom 50% of the people cost us only 3.5% of the money. So let's try to help people be healthier, and that really comes to, and I'm going to be a little windy, but it comes to what is health. And you know, I've thought about that a lot because health is kind of ethereal. It's kind of like, you know, Maplethorpe, you know it when you see it, as opposed to, but I had my epiphany. So I was talking to another distinguished group of people, maybe not as distinguished as this group, but it was the Navy SEALs. And I had my white coat on, and I was, you know, very professorial and using my big room voice. And I'm like, you know, it's great to see you guys. You're America's, you know, pride and joy. You're really healthy. And one of the guys' hands went up. And I'm sitting there to myself, 15 seconds in, going, what did you not understand about what I just said? Maybe not the smartest people. But of course, it was me that wasn't so smart, because he goes, Doc, let's make sure we're on the same page. We're really fit. We're not really healthy. We have high cholesterol, high blood pressure. We get deployed and do dangerous stuff. We drink a lot. We have our days and nights inverted for months at a time. We're not very healthy. We're really fit. And so it made me think, so what is healthy? If we want healthier communities and populations, then what is health? And to me, it came personally that I have children. And when they fall down, they get up really quickly. And when I fall down the same way, I'm calling the emergency squad. So I know that I'm not recovering as fast as they are. So I think youth is health. And so my own bias is that when your biological age is less than your chronological age, you're healthy. And when your biological age is greater than your chronological age, you're not. And so when we think about disease, whether it's heart disease or stroke or cancer, and I'll say opioid stuff too, but I might put that aside because I think there's a connection. But I think that is happening in our population with more prevalence and incidence because we are getting older young. So I think that our population is aging. And the two reversible things that I, at least as I read, and we still do some research, and is that you don't want to smoke because smoking actually causes disease by aging you. It activates the Werner's protein. Werner's is a precocious aging problem, so don't smoke. And the other thing is that across all species, there's only one thing you can do non-genetically to improve the outcome, the survival of these species, and that is calorie restriction. Now, some people say not worth living if I have to go there, but nonetheless. And it's interesting that when you look at the process involved, it's called autophagy, and autophagy is self-cleaning. It's when the cells start their own garbage disposals, getting rid of sort of damaged organelles. And the pathway that blocks that is PI3 kinase, and the most common way we activate PI3 kinase is sugar. So the insulin receptor being activated activates PI3 kinase, blocks autophagy, and so we know the average American eats about 100 pounds of sugar a year, processed sugar. That means you guys too. And so reducing sugar intake probably activates autophagy. So those are the things you can do. But the other things, if you look at longevity studies, is really about community. You know, we're going to have Dan Buettner visit. Dan Buettner did the blue zones, the 5 areas in the world where people live long and well. Well, I was on winter vacation with our family, and we rented a house in Florida. You know, West Virginia's cold, Florida's warm, and so we went in the room or in the house, and there's only one book in the whole house, and that book was the Blue Zones. And I thought, well, maybe I should read that again. And when I read it, these people were really poor, but they lived intergenerationally. They had a purpose. They believed in a greater sort of reason. They trusted. They loved each other. And so when you look across multiple different studies, whether it's longevity study, the Harvard Grant study, the Blue Zones, it turns out that community really counts, that, you know, deep connections to people, deep connections to purpose, and seeing the world as positive. You know, Elizabeth Blackburn, who won the Nobel Prize for telomeres, which are the end of DNAs, the longer they are, the younger you are, the shorter they are, the older you are, demonstrated with Alyssa Appel, a behavioral psychologist, interviewing a group of moms, and they had 2 groups of moms really closely matched. One group had really sick kids, and one group had well kids. The sick kid group of moms they thought would age faster because they're all worried about their kids, and the well group of kids, moms, they thought that they would age slower, and they measured telomeres. But what they found was really different. They found that no matter what the status of your child's health was, if you felt stressed, you aged faster than if you didn't. If you felt grateful, if you felt happy, if you appreciated your life, you're good. And so it's really, I believe, in mindset, it's how we see the world, not how the world is. And I think community helps build resilience because we have people that help us see the world better. You know, if you take, and I'll stop after this, but if you take a person from an endogenously healthy place, and you move that person to an endogenously less healthy place, that person will take on the characteristics of the unhealthy place. You move a community of people from an endogenously healthy place to an endogenously unhealthy place, they do great. So there is a benefit to community, and I think anymore our communities are breaking down, and that's what I think is so powerful about this forum. This is a community, and if we as community members can have a greater purpose and goal set, I think that has a tremendous amount of power.
So now tell us a little bit more specifically what you're doing in West Virginia. I mean, I imagine you're seeing the real life impact of the trends Steve reports in today's signature report. Tell us some of the things you're doing to address that.
Sure. So we've done a couple of things and maybe a little bit atypically. So we have tried to apply the Herb Kelleher model to our own team. And the Herb Kelleher model for Southwest Airlines, as I understand it, were 2 things. One relevant to us, one not. The one not relevant to us is you put the luggage with the handles out so you can flip the plane faster. Well, you know, maybe eventually we'll take up a second business to pay for everything. But the one that's relevant for us is you start investing in your own employees because the health of our own people was not very good. And so we have now started to move a lot of the measuring things backstage. We're still measuring things. We still know who prescribes what. We still have evidence-based practices. We have electronic medical record. We're on Epic. But we are not focusing that on our team. We are relieving our team and helping people feel creative and giving people the outcomes we want to see and let them try to arrive to get it so that they can feel like they own the solutions. And what we're also doing, so we are growing our healthcare system. We have created 5 service line programs. One of the service line programs is heart and vascular. We have hired 35 new physicians for that program in the last year. We have hired 225 physicians total in the last year. We have expanded our size in our medical center by 4,000 people in the last year and a half. And we are now the largest employer in the state of West Virginia. But we are collaborating with everybody. We are not competing. We're working with every other health system in the state. We're trying to exchange information. By statute, we are an extension of the Department of Human Health and Resources. So we actually are working in series with the state, not necessarily in parallel. And we are trying to come to the point, as Mike talked about, that we want to take risks for people in the state. Because right now we benefit from people being sick, and the sicker the people, the more stuff we do to them, the more money we make. You know, case mix index, we even have a name for it. But fundamentally what we want is we want to marry health and health care. And we're starting to invest in coalitions and community activists that are really making a difference. So For one example, there's a family medicine physician in Mingo County in Williamson, West Virginia, Coalfield area. He was the student body president of West Virginia University, and we, in all of our knowledge and wisdom, turned him down for medical school. So he went to the osteopathic school, and this guy's done pretty well, so that was on us, not on him. But he trained as a family physician, went back to his hometown, and he opened a clinic and couldn't fund it because people didn't have enough money, so he became an FQHC. He started a walking club, and they were going to walk across West Virginia, and that happened in a month, and so they were walking across the country, so they actually walked to Marin County, and Marin County started walking back to Williamson. So you talk about really making a change, started a community garden, started a mobile market so that people could get good, fresh food. In 2014, Williamson was named as one of 6 Robert Wood Johnson Culture of Health Award winners in this country. And Dino Beckett, the doctor, was named 2015 as the Rural Physician of the Year in the United States from West Virginia. So he's doing great stuff. We're supporting him. We're working with him and Stanford University to bring social entrepreneurship to West Virginia. We know that having small businesses, having entrepreneurs in cities makes healthcare metrics better, whether it's because it gives people purpose and hope, or whether it's because you're bringing the most resilient people in the world, the people that no matter what happens, I'm always going to get it the next time, high grit scores to West Virginia. And so we're working with a few companies, what we've called outside-in commercialization, where we've opened up our borders and said, come and play, and we won't charge you. And we have a big health system, 10 hospitals, and come and try your stuff, so we're doing that. We have a group called Try This West Virginia, which is a micro grant group that has given out 600 grants of $5,000 or less to 3 community groups that have to come together. And people have built ballparks, started bike clubs, started walking clubs, started running clubs, built grocery stores together. And so we are helping with second stage grants where you bring the 3 of the groups that have already done stuff together, and that's up to $50,000, and we're making a change there. And there's a bunch of other stuff, but I'll tell one more story. There's a program called the Coalfield Development Corporation. I talked about this yesterday with the opioid panel. And this is a young guy named Brandon Dennison. And Brandon Dennison is kind of a missionary-like guy. He's got a purpose and a meaning, really young guy. And he's created this program, and he calls it 3363. And he works with, initially was really for out-of-work coal miners. And what it is, it's 33 hours of work. And this is in agriculture, solar, and artisan furniture manufacturing from reclaimed barn wood. And 6 hours of community college, and then 3 hours of personal leadership training like how you keep a checkbook, how you do an interview, how you dress for success. I mean, a lot of that kind of stuff. And the lives of the people that have been engaged in this has been stunning. And so we're now putting that on the other side of our residential recovery program for people with opioid dependency, so people have something to go back to. So our goal is, let's put everybody back to work in the state of West Virginia. Let's give everybody a purpose. Let's give everybody a community, and we think we can change it.
Mm-hmm. Did you have, I'm sure, some surprises along the way, either negative surprises or positive surprises? I wonder, anything unexpected that happened as you were driving some of these initiatives?
Well, I would say that, first of all, we're really not driving anything. What we've decided to do is we want to support the people who are doing the great work. A guy who works with me, who I love, he says that we are the wind in the sails. So, we want to help people find the right line to tack to, and we want to support that, but we don't want to tell anybody what to do, because if we come in and say, here's what you do, here's what the evidence says, everybody's going to be like, yeah, heard that. You'll come when you have a grant, then you'll leave. And so what we're doing is we're coming in as community members and we're supporting things. And we're working with the National Guard, we're working with our extension agents, which are people in every county. But the thing that's really surprised me, I guess, in West Virginia, we also have a Clinical Translational Science Award grant from the NIH, and with our matches, that's a significant amount of money, about $55 million. And we have opened a practice-based research network of 74 different places in the state, and we are serving those practices. They tell us they want something. For instance, Cabin Creek, which is where Jerry West is from, if anybody's a basketball fan. But Cabin Creek, West Virginia, is a rural community, and they were getting killed with hepatitis C from IV drug abuse. And so we and them and a group from the Cabin Creek practice went to New Mexico and trained with Dr. Aurora, who came up with the ECHO program, Extending Community Health Outcomes. And we've started echo programs now for Hep C, for addiction treatment, for behavioral health, for for cardiac prevention. And I guess the thing that's really impressed me in West Virginia, maybe not surprised but impressed, is the intelligence of the people that we're working with. We've got a lot of really amazing people, and the commitment of these people is palpable. And so unleashing that power and helping people being seen and heard from the things they're doing and trying to coordinate things, I think has been really, really inspirational to me. So.
And Mike talked about how they engaged physicians by really having the physicians go in and take a hard look at how they were practicing, whether that's hospital-based or whether that's clinic-based. What would you say that you did within your system? Did you have challenges engaging the caregivers or providers? And if so, did you use similar approaches?
Well, maybe a little bit, but maybe a bit different. So I have to say, so I'm a pulmonary and critical care physician, and I was at Ohio State. I'm a native of West Virginia, went to undergraduate medical school at West Virginia University, but I was at Ohio State for 30 years and oversaw some clinical stuff and some research stuff and some innovation stuff there, and also oversaw personalized medicine for a whole bunch of years. And what I believed when I was at Ohio State is that we had it, Gordon Gee, our president, talks about we were looking through the wrong end of the telescope. So we actually flipped the telescope backwards. And I started to think about it. If we were a restaurant, I'd want to be a restaurant for other chefs, not for competing for customers. And if we could make this a great place to work and a great place to be, then I thought that we could do great things. So we have really gone away from trying to incentivize people with RVUs because as RVUs, relative value units, so how much work you do, how much stuff you bill for. Because when I was the head of the pulmonary critical care group at Ohio State, everybody wanted to work in the ICUs. And why was that? Because per time spent, you could generate a lot more credits, RVUs, in the ICU than you could on the consult service, even though the consult service is really important and was a much harder job. And so we are, to me, incentivizing the wrong stuff. You know, the Einstein thing that not everything can be measured as important and not everything important can be measured. And we wanted to get people to stop thinking with their brains and start feeling more with their hearts, to come to work because that's what their passion was. That's what the magic was. And so what we've done is we've moved our measures backstage. So we're not necessarily telling people, here's how you compare to other people. I mean, the chairs kind of know that, but at the usual worker level, we don't really tell them that. And we tell people, here's what we want to see from the practice. You know, we'd like to see the days waiting go down, and not because we're keeping a chart, it's because there's a lot of people that need to be seen. We want to help you, tell us how we can help you. And some people say, well, give us more infrastructure, give us a pharmacist. And we're trying to do that because we anticipate if we have a happier workforce, it will be more productive. And if fun is what you want to do, work is what you have to do. And if you're really in for the right reasons, you will extend yourself dramatically, and we're starting to see that. And we're certainly not perfect, and it's early days, but I'm very enthused, and people really now are starting to become committed for the right reasons to what we're doing, and I feel kind of more like NASA first man on the moon than NASA O-ring place right now.
Mm. I'll ask you this question before we go to audience questions, and then I'll ask it of Mike as well. How is your measurement set up? So when is a checkpoint where you're going to look and say, here's how we're doing health-wise, or certain specific measures?
Yeah, a lot of people ask that. I think that there are certainly metrics. I mean, we follow lists and rankings like other people do, but I hope that we're not lost in that, because I think a lot of times we'll say, oh, we're successful because we're number X on a list of whatever. And I think that if we can follow our purpose and not get that confused with our business, and if you look at universities in general, the purpose of medicine to me is help people be healthy. Businesses take care of sick people and do stuff to them. The purpose of education is to inspire people to learn. The business is ranking, selectivity of the university, scores on this test or that test. And for research, the purpose is to solve important problems and improve people's lives, and the business is grants and papers and National Academy appointments, et cetera. And so I think that if we can be a place that really changes people's lives, starting with our own team and then moving beyond, then we'll have been successful. And based on the fact that we have added, in the old days, we at WVU, we lost more people per year than we gained. We lost more people left WVU at the medical center than came. And the last year, we hired 126 people and we lost 20. So I think that retention and helping people grow and building that momentum is the biggest success factor that we see. And we do a lot of querying in our own team about what things can we do to make your life better, to make this place a better place to work, et cetera. And so I will pay most attention to that. Other people, I will say, will pay attention to what our base cash on hand looks like and, and all the other metrics. And I know those too. But I think that focusing on the right stuff makes the biggest difference.
And Mike, can you share with us what your metrics are? How are you looking at success and at sort of what time points?
Sure. We, as an organization, have a balanced scorecard that we look at because no margin, no mission. But we look to basically break even on our business. We're not for profit, and so our investment income can help carry us. But what really drives us are the metrics of quality and metrics of service. And so quarterly, we're looking at our metrics. But whether it's internally looking at that scorecard or whether it's across the community and looking at county health rankings and behaviors and the BARFIS type of data that doesn't come out as frequently, it isn't so much about the metrics, it's about the conversation that the metrics brings about to get the engagement that we want. And so while we have a consistent set of metrics that are balanced, it really is about bringing the right people together and talking about, well, what does this mean? What are the opportunities? What can we be doing next and differently that can help to drive this together? And so those conversations really help to promote that sense of ownership and that we're really in this together. So we do try to make sure that the metrics have that sense of it's not something that is being reported about you. It's something that you're truly invested in.
Can I just make one comment? So I think that the point you just made, Mike, is so important. And I've read this, and I think this is what most people's experiences are too in their own world, is the level of engagement of people equals the outcome of the organization. And if you get very engaged, very committed people, the place just gets better. And the service gets better, and all the other things get better.
Mm-hmm. So Steve, after hearing what they're doing in their communities, I wonder if you're starting to feel a bit better after immersing ourselves in the wrong direction.
Well, I think it's easy to feel good with a variety of people that we have in the room here. So
I think you're right.
It's a comfortable place for that.
So I think we're ready for audience questions.
Thanks. Hi, I'm Katie Adamson with the YMCA, and my question, a little background, is that we're working over the next 10 years with Robert Wood Johnson Foundation to be a little bit radical and integrate the community into the health system. They say that at Robert Wood Johnson, 80% of health outcomes actually happen in community and 20% happen in clinical setting, and we want to be closer partners with the clinical setting, with reimbursements and referrals and integration. So we're building Ys with hospitals, we're building Ys with schools, we're putting clinics in the Y. How do we do this? We have evidence-based programs that docs are referring to now. So my question to you is, how do we expand the medical home to include a larger population of workers, including community health workers, including expanded referrals to services we might never thought of, like food systems or transportation or childcare, to make the determinants of health less impactful on people's health outcomes?
I'll go second.
Okay. I really appreciate the question, and the YMCA is a vital partner for us. We invested in a YMCA that's actually the Y that I regularly go to. Wasn't selfish, but we wanted to create a Y that did just what you described. And so we went, looked at a couple of Ys and saw that there was an opportunity to build a facility that not only had the typical Y capabilities, but would house a physical therapy practice, occupational therapy practice, tried to get a primary care practice there, but couldn't make that happen. But the idea being that we wanted to start by having an opportunity for people who would truly benefit from a lifestyle change. Those who underwent joint replacement, those who were going cardiac rehab, they could do it in a place where they could then transition to continue it comfortably. It was familiar, they knew the equipment, they knew the people, and that would just kind of become a new part of their life. And I go there, and it's amazing how well that facility is utilized and how diverse the population is. Because actually, I had the good or ill fortune of having a shoulder problem, and asked the orthopedist, which physical therapist should I go to? Who's the best for shoulders? And he directed me to the physical therapist at the Y. And went, saw him, and progressing through the rehab, I got to the stage where he then took me upstairs to the equipment and showed me exactly how to use it. And I thought, wow, this is so cool. This is exactly what we wanted to have happen. But we have to go further. And in some cases, it will be plans like ours that are willing to step out and innovate and recognize that you can do more in those settings with nutrition, with education, and with other activities that you're probably better at because you've got trusting clients that come to you on a regular basis. So some of that will come from innovative plans that are willing to step out. Some of it's coming through the government in terms of what's happening now with Medicaid and DSRIP programs that are being funded and really reaching out into the communities for non-traditional partners to help provide some of the things that you described in the context of the health home. So I think that there clearly is a recognition that the traditional walls where health systems ended have to be broken down, because the trust and the engagement that you're going to get from the community is far more important than the knowledge that's been held within the health system if we want to bring about the change that we're talking about.
And if I could just add, so I think that the Y is a great example of an opportunity that we have in communities. And it's interesting that we were working for a while with PricewaterhouseCoopers in extending a study they were doing with Walmart and some other partners around diabetes management, using sensors and trying to outfit people with diabetes so that they could have more active knowledge of their own disease. And as part of that study, they hired people to go visit people in their homes outside of the hospital setting, and they called these promotores. And when they looked at all their data, that was the only thing that made a difference, was somebody coming and checking in on you and paying attention and caring. And so I think that the Y could be, and I think for many people, is a gathering place, is a hub in the community. And the more of these hubs that we can create, whether it's around exercise and rehabilitation and being able to bill for it, or whether, one of our ideas is we want to create a series of community kitchens. Because if you think about when people come over to your house, where do they all hang out? They hang out in your kitchen. Food is part of our social setting. So instead of a community center with a basketball court, we think a community kitchen or a community center with a kitchen to be able to bring fresh food from chef farmers to communities and host a meal a few times a week where the whole community could come and be together, and maybe could have some music, maybe have some programs. Maybe this is a place where people could have other programs offline, off time. But I think that could promote health. But to make that sustainable, and this is really the issue for most of us in the room who do healthcare, then you have to figure out the financial model. And to balance the purpose model and the financial model is where the secret sauce starts, I think.
If I could just make a brief remark, because I do work in at least volunteer time in the public health world. Seems to me that the Ys would be a really wonderful place to promote, the 7 healthy lifestyles for cardiovascular health. And so, in other words, to be not just a treatment center, but to be a promotion for cardiovascular health and to move those things along.
Hello. Hi, am I next or?
Oh, sorry.
That's okay.
You have the microphone.
So, good morning. My name is Paul Geist. I'm from the National Institutes of Health and also from Johns Hopkins Bloomberg School of Public Health. And first of all, I want to thank the forum and John Clymer for having me be here for this meeting. And what a great first pathway panel discussion to kick the meeting off. And also one more thing, to thank John Clymer for continually, when I ask him and create the opportunity to come to Johns Hopkins and help our graduate students know about the mission objectives and the good work that the forum does, and the whole area around cardiovascular disease and health promotion, disease prevention. So thank you for that, John. My book's already filled with a bunch of notes, and so first an information factoid and two questions. Dr. Marsh talked about, and thank you very much, about the influencers and how to align for behavior adoption and health promotion. There is something that is called also the peer opinion leadership model that was developed by Jeff Kelly that is a mirror to what you're saying, and there's a rich literature that would be worth knowing about and seeing. The other part of that as well is understanding that in any system, there's also the countervailing forces that also know about exactly aligning the different information influencers and motivators. And sometimes they're actually working with what I would call less than stellar evidence to create a counterpoint. And so for all of us, it's important to monitor those systems and to understand at any time we may also have to develop a strategy to counter that as well, because that's working. They win if they don't necessarily win the argument, but if they neutralize ours, then that's success. So the two questions. One, it really, we've talked about, Dr. Cropp, I think, emphasized this in particular, but the whole panel about behavioral and social influences and how that needs to come into prevention. We all know this. And I think probably later in the day, policy will be talked about because we can work even recognizing the context, whether it's at the Y, et cetera. Dr. Cropp talked about how New York City or New York was the most resistant, and that was probably a policy issue, and it was probably, my guess would be, once cost effectiveness and cost savings started to come into the equation, you probably started to get a little more attention and flexibility around things. So at some point, if the panel could talk about the role of policy in cardiovascular health and prevention of disease. And then the second is the role of HIV and AIDS, where we have in the HIV positive population versus the HIV negative population, a higher prevalence of comorbidities of cardiovascular, lung and blood diseases. And it's estimated by 2030, 78% of the HIV positive population will be diagnosed with a cardiovascular disease. If you have how that fits into your overall schema, I would appreciate hearing about that as well. Thank you.
I'll give it a start.
Go ahead.
Yeah. So I appreciate your comments and questions. You know, it's interesting that when you start to look at complex systems, the other thing that's key is that everything is interconnected. You know, the butterfly flapping its wings in South America, you know, changes the weather patterns. And so I think that what we need to do from a healthcare system delivery, health, community standpoint, as well as a human being standpoint, is start to look at facilitating the ability to adapt quickly and to become more resilient. So you can't predict what's going to happen. You know, Nassim Taleb has wrote a great book called The Black Swan, which is really about asymmetric risk and how he identifies things that are going to fail massively. So he bet big on the 2008 housing or the 2008 housing market, and so when you look at things that are going to fail, he thinks these are things that have lots of rules, lots of processes, top-down managed, which he calls fragile systems. And I think that when you look at our bodies and our government and our healthcare enterprise systems, we're all fragile. You know, we tend to want to lock down things when things get more complex to give people a better feeling of control. But in fact, that makes us more rigid and less able to bend, right? The oak tree is real strong, but in a big windstorm, it falls down because it has no flexibility. The palm tree, on the other hand, will go all the way to the ground and survives a great storm. So I think that there's a similar sort of approach to looking at disease burden and looking, say, for instance, at HIV, your point and your question. You know, Paul Ridker, who's a guy I got to know a bit, just did a study in New England Journal looking at trying to block inflammatory mediators to try to reduce coronary artery disease, and he's done a lot of work on CRP and the role of CRP in inflammation. Similarly, if you look, a friend of mine, Sanjay Rajagopalan, has a research enterprise that looks at the inhalation of particulate matter, PM 2.5 to 5 micron inhalation of particulate matter, which accelerates coronary artery disease dramatically. So our bodies, I think, are really resilient machines in some ways, and that as we have things that take us off balance, I mean, you think about it, 10 to the 12th cells every day die apoptotically, which is 10 times 10 times 10, 12 times. So our bodies are controlling things really, really well. But when you have an infection, chronic infection like HIV or other infections, maybe that stimulates, particularly depending on where they settle and what the ramifications are, that starts an inflammatory response that starts to unbalance the body. And I think that, you know, as we look at HIV, because when I was training, HIV was a death sentence, and now HIV is a chronic disease, which is an amazing success, by the way. I mean, really powerfully amazing. But now it opens a whole, it's a complex system, so there's new things that come up. So to me, that's where the field needs to go, right? I mean, part of our research mission is not just to get grants and put papers out in high-impact journals, but to solve the problems that help people live better lives. And we solved a problem to help people live lives in HIV, and now the question is what's next? And there's always something next, right? I mean, there is you know, Ebola, there's opioid addiction, there's TB, so we are always fraught with a changing system that is very dynamic. And what Taleb says is the goal to create a system is bottoms up, is anti-fragile, right? Childhood prodigies are never adult prodigies, because childhood prodigies are told, hey, you're great at doing stuff, so they don't dare to do more stuff. Adult prodigies are great because of what? Practice. How much practice? 10,000 hours of practice. And if you read Lincoln's book, Team of Rivals by Doris Kearns Goodwin, I mean, his whole life was, you know, learning from mistake, but that guy became, you know, one of the greatest people in the history of our country. So ultimately, it's really about adaptation and learning and rapid cycle innovation and research that can solve the kind of problems. And I think from a behavioral standpoint of changing behaviors, I think nobody's going to listen if somebody tells them what to do. When I was a kid, my parents told me, cut the grass, cut the grass. I'm like, oh, I hate to cut the grass. And then we got our first house. I'm like, oh, cutting the grass is great, my grass and all this stuff. Now, I did mulch a weed at one point, but that's a different story. But I think that the bottom line is if we decide to do something, it's much better if somebody tells us.
Anyone else want to comment on that?
Sure. You know, if learning by mistake were the sort of the yardstick, I should have a PhD by now. I can't speak to the HIV issue uniquely, but I do want to talk a little bit about policy, because 8.5 years ago in this very room, when Atul Gawande wrote The Cost Conundrum, and it created a little firestorm around the Affordable Care Act, one of the things that I think resulted from that conversation was the quality bonuses that were built into Medicare Advantage payments by CMS. And that was really the first step, I think, in the right direction to influence policy in the right way. Now, the STAR system is somewhat immature and it needs to be updated to reward, I think, more of the right things, but it's beginning to move in the direction that Clay's talked about in terms of promoting health and not just health care. The other policy dimension that I think is important is that we have to broaden the conversation about the importance of health in terms of the impact of health or lack thereof on the economy. And one of the things that we've been pushing in New York State is to recognize that the health value of a community will probably be the single biggest determinant of the economic success of that community in the future. You know, given the 6% trends that have been going on, you know, New York State's been a challenge because of high taxes, and upstate the cost of power, but the cost of healthcare will eclipse all of that, you know, in the near term. And so the communities that get this right will probably benefit economically. So what we've done is taken that to Albany to have the health folks and the economic development folks come together and to endorse a health value scorecard that is now owned by the economic development folks and bringing them together to really talk about this. And so when Governor Cuomo has set up an economic development model that is a competitive bidding process, we hope to get to the point where some of the rewards that are doled out in the future are based upon how is each community doing in terms of managing the health value. And so that they'll be spending more economic development dollars in those communities that have demonstrated they're fully invested in this. So I think that for us is a major policy approach that we're looking forward to seeing come forward.
Oh, go ahead, Steve.
Yes, and I'm going to go off course here, or what might seem off course for a moment, but I do think I'm not expert on what we might do for HIV, but probably once again, you know, the healthy behaviors is probably something that we ought to encourage in everybody. And I want to bring up another chronic condition because it involves my family, which is autistic spectrum disorder, because that's an epidemic, and that's going to hit adults very soon with about nearly 2% of kids being diagnosed with it. I have an autistic son, and the reason I bring this up is because he was starting to get obese when he was about 11 or 12, and I was looking at him and said, oh, this is going to be a disaster. So I started jogging with him a couple of minutes a day. And, you know, later on, he went out on to the cross-country team in high school. He was the slowest guy on the team. I actually went out to practice with him every day, took off from work and did that. But the point I'm getting here is autistic spectrum people tend to internalize their routines. So that now he's 35 years old, and basically, unless there's something else going on, every day when he comes home from work, he goes out and runs or walks about 3 miles a day. And, you know, we in Kaiser have taken a look at our 4,000 or so adults with autistic spectrum disorder, and if you look at their profile, they have higher rates of every chronic thing you wouldn't want them to have than a regular population. So this is a group that's, we're going to see a lot of cardiovascular disease in, and they're a great target population for the types of things we want to do, because maybe not all of them, but a lot of them I would expect are probably going to internalize good behaviors.
That's a great story. We have a very patient questioner. You've been standing since the beginning. In the red sweater, do you not have a microphone?
Even more patient. Yeah.
Well, then you're the most patient in the room. Then let's go over here.
I'm Jim Malore.
You're on.
You're on. Yeah.
Okay, Jim Malore from the Minneapolis Heart Institute Foundation. This is primarily addressed to Steve. It seems to be my understanding that in Europe, they approach prevention a little bit earlier than we did on a national basis here in the U.S. I'm wondering if there's, in seeing that our cardiovascular disease rates are slowing down or declining or going up, Are there similar data available from countries in Western Europe that have initiated prevention programs earlier on than we have? And if so, is there anything that we could learn from that?
I don't know enough to speak to the timing or anything about the prevention programs per se. There may be others in the room who can do that. But there are, published data about international trends. And they're basically, it appears that the same sort of thing is going on internationally. It's I think it's the global, I forget the name, global burden or global of diseases study where they've looked at many countries. And they've looked at different, levels of SES, and it's, happening, we're relatively high SES. It's happening in them too. So, the obesity epidemic is international. These, what's going on with cardiovascular disease mortality appears that it may be international as well.
Can I make, so one point, and I can't tell you the answer to your question either, but something that I'm really fascinated about is something called the Adverse Childhood Experience Survey. Are you guys familiar with that? Which is a 10-question test done by the Kaiser Family Foundation. And it's about trauma, neglect, and family dysfunction in children 18 and under. And an answer to any question, yes, increases your risk of anything bad. Heart disease, stroke, cancer, obesity, diabetes, overdose, addiction. 4 out of 10, yes, will give you a 1,200-time lifetime risk of having emphysema. 6 questions, yes, will give you a likelihood of living fewer years than if you had 0 yes, up to 20 years. J.D. Vance, who wrote Hillbilly Elegy, had a score of 7. And you would have thought he would have done poorly, but the offset are resilience factors. People love you, people that give you opportunities, make you feel special. So I think that one of the really critical issues for us as we look at sort of global health and disease is this idea that, that many people are traumatized, whether it's in their childhood or in their adulthood. And, Ann Case and Angus Deaton found the same thing. Deaton won the Nobel Prize in 2015 for economics, that there's a group of 45 to 55-year-old white people that had a high school education or less that are dying at a rate not seen since the peak of the AIDS epidemic. And they're dying of despair and hopelessness. They're dying of a loss of social capital and perhaps social isolation. So I think that the answer, in part, and I don't want to simplify it because it's not, it's very complicated as you guys know, but one of the answers is we need to help return resilience to our communities, and we need to reconnect. Because I think everybody is separated. Everybody has their own channel. New York City, people have their earphones in, reading their books. We don't talk to each other anymore. We don't know each other. We're on our phones. We're on our electronic devices. And I think one of the opportunities for us as a community here is to come together, but also bring our communities together.
I'd like to just pick up on the resilience piece. It's not that we've given up on the current generation, but we're really spending more time focusing on the next generation and trying to get at the obesity issue and some of the behaviors. And so we have a foundation that has been focused on working to help kids create better habits and to give them more opportunities. And we've run a Fit Kids program in public schools across our region for about 10 years now. And we partnered with the Buffalo Bills starting 3 years ago. The NFL has this NFL Play 60. And so we figured that amongst other things that we could do with the Bills, that we could power together. And when we connected the Fit Kids program with the NFL Play 60, we increased the participation in the NFL Play 60 5-fold, which has been really, really cool. The Bills, the players love it in terms of connecting with the kids. The kids absolutely love it. But then we've got this other program that it's called Soccer for Success, the U.S. Soccer Foundation. And now we're in our 6th year with that. And we get about 3,000 kids in the city of Buffalo who 3 days a week are out there learning soccer skills, but learning skills, life skills. They've got high school coaches and college kids who are coaches who are teaching them some of the basic lessons that they need to know, nutrition, fitness, and other life skills, and they're creating mentorships and partnerships with these kids. And it's just incredible to see. We're seeing actual results in terms of BMI reduction, but what we're now beginning to see is some of those kids who came through coming back to be mentors. And the whole theme of what we do with the foundation is building resilience in childhood, and reaching out to form partnerships across the community has really, really helped to extend that reach. And again, it's not that we're giving up on the current generation, but I think focusing on the next generation, like Steve's talking about, ingraining those behaviors early on, there's a lot of promise there.
I think I have time for one or two more questions.
Hi, Stan Shanling from Minnesota Department of Health. It seems to me, Stephen, if we looked at trends and what you're seeing in your analysis, that I'm going to hypothesize, and there's some themes that are going on here, that motivational change and behavior change probably mirrors what we're seeing. And I'm thinking that populations are being motivated differently today than they were 25, 30 years ago. It might be a function of, all the toys that we have available to us today, or the fact that we're in a fix-it mentality. Don't worry, if I have heart failure, somebody will take care of it for me, not a problem. So I think some of that is inherent in some of this trend stuff that we're seeing. But underscoring all of the things that we're seeing here is sustainability, whether it be sustainability in good trends, whether it be sustainability in programmatic efforts, etc. Question. CDC is soon going to be giving out grants and new grant cycles to states around the country. What would you recommend to CDC with new grant cycles to states around the country from a public health perspective?
Who would like to take that? Clay, do you want to start?
Sure. I mean, I think that that certainly CDC, through their different programs, has certainly made a huge difference in the health of our country. And when we look at public health, as Stan, I know that that's your background and your focus, then I think public health needs to change to public and population health. And I think as we start to look at the impact of opportunities in community building and facilitation and access to different types of connections, et cetera, then I think that doing work that will extend the sort of the traditional public health into reaching out and forming other types of partnerships, and we heard from the why before, but I think that there's many opportunities to do that, to provide access, say, for instance, to better food for people, or to provide access for cleaning up communities, or providing access for looking at building resilience. And there are certainly programs that could be done to try to help people feel differently about their own circumstances and empower leaders and communities to try to rebuild communities. So I think that work, say, Robert Wood Johnson's trying to do now with their Culture of Health program, the CDC, private, businesses and foundations, I think it's time for us to start to take partners. John Seely Brown said that real innovations happens at the interface of disciplines or edges. And I think it's time for us to have the federal government also look at new partnerships and new alliances that may actually enrich the abilities that they have to make a difference for American citizens.
Anyone else?
I think, just to pick up on what Clay has said, that CDC has an interesting opportunity, even with one of the programs run by the Forum in terms of the Walk with the Mayors, to kind of to be a catalyst, to put some incentives out there, to bring communities together to support something like that. We were talking yesterday at the board meeting about the League of American Bicyclists has set sort of criteria for platinum, gold, silver, and bronze communities. And there's huge competition out there that brings communities together to raise the bar. And the CDC could do something like that with walkable communities. It's not a huge investment, but you could set the table to really bring communities together to create the safe environments, to create the opportunity to really promote these kind of healthy behaviors.
And I would just add, I don't have anything to add to these great responses here, but I do have one upstream kind of recommendation, is that it appears that the CDC is heading for a cut in funding, and I think anything that we can do to advocate to keep it at least funded at the levels it's accustomed to would be very helpful.
Well, we are at time. I hope all of you feel that, as I do, that while some of the trends discussed in that Steve's signature report, that there is great promise just by hearing from the vision and of the people and organizations such as Dr. Cropp and Dr. Marsh. So I want to thank them for being on our panel today and sharing the work that you're doing. And of course, thanks, Steve, for all your hard work in delivering this report today. With that, we will break.